Okay, well, we'll get started now, I think, because I know everyone's busy. Thank you for coming to this webinar today. I'm Jeff Schweitzer. I'm an assistant professor of neurosurgery at Harvard Medical School and Mass General. And the subject today is focused ultrasound treatment for tremor. And I'm going to give everyone a little bit of background about what this is, how it differs from other treatments that you may have heard of, such as deep brain stimulation, who it's for, and a little bit of information about how the treatment is done, what the coverage is for this, and at the end, I will have a slide with my contact information, phone numbers, emails, and a QR code that if you'd like, you can take a picture of that, and that will also have contact information. We'll try to get some questions at the end, but if we run out of time or you're busy and have questions for later, please feel free to email me or contact me through any of those other means at the end there. So in the way of disclosures, there is only one company that makes the equipment to do a focused ultrasound, that's Insightec. And so some of the slides that I have here are from them, and they are helping me organize these webinars, but I am not paid for them, nor do I work for them. I do DBS, I do all types of functional neurosurgery, but just, by way of disclosure so that you know where some of this information is coming from. And let's see here. Okay, so tremor. There's basically two types of tremor that most people will see, both in neurology and in primary practice. The most common type is essential tremor, meaning tremor where the cause is not really known, although there's some hunch as to how this may work. Essential tremor is basically an overactive feedback circuit where the body's unable to maintain position because it's oscillating around the desired position. It's a postural and action tremor, rarely occurs at rest, and it's very common. Up to 40% of the adult population over the age of 40 has tremor to some degree, depending on what you consider to be normal physiologic tremor and what you consider to be a problem. This is also called familial tremor because it commonly, but not always, runs in families. This is the kind of tremor that goes away with a little bit of alcohol. That's one thing that is a characteristic that most people will have noticed. It also responds to beta blockers and primidone. Again, it's the most common type of tremor that most of us see. But Parkinson's disease is what most people don't want to hear when they develop a tremor, because it has obviously other implications and many other symptoms, including the slowness of movement, stiffness, rigidity, postural instability, and in some people also cognitive issues. It is the second most common neurodegenerative disorder and affects more than 1 million Americans. Parkinson's really comes in three flavors. There's akinetic rigid, there's the tremor dominant, and then there's the gait and postural instability type. All three of these are potentially treatable with focused ultrasound, but it is not often used for things other than the tremor dominant indication, because some of those other issues can be a little bit more difficult to treat without finer tuning. But there are people who are not candidates, who don't do well with medication, or not candidates for DBS with other symptoms of Parkinson's for which focused ultrasound can be considered. Today, I'm really going to concentrate on the tremor indications for these two diseases, essential tremor and Parkinson's. The idea of doing surgery to correct movement disorders is not a new idea. It predates the use of medicine, both for essential tremor and especially for Parkinson's. The medication that's the standard for Parkinson's, Sinemet, levodopa, it was initially used in the late 1960s. The history of surgery for Parkinson's goes back at least to the 1930s. There were some operations that were done to actually cause hemiparesis. A surgeon would cut the corticospinal tract in order to relieve the tremor. It was so bad. And the most of the operations that we have today, including DBS, developed out of observations that came from those early operations. There's a whole history behind that, which I'll go into slightly in the next slide. But what's happened over the 20th and beginning of the 21st centuries is with the improved imaging, neuroanatomical knowledge, medical technology, the types of operations that we can offer patients have become much more refined and effective, and the side effects much less common than they were with the earlier operations. Again, long history for this. Horsley and Clark, going back to the 19th century, developed stereotactic frame, which is a device that can be placed on the head in order to point precisely at places in the brain that we want to treat surgically. In the course of one of those operations to paralyze a patient to stop the tremor, a surgeon named Irving Cooper accidentally interrupted the intercoroidal artery, which caused a small infarct in the basal ganglia, and observed that the tremors went away. And this led to a series of operations back in the late 1940s and the 1950s that brought all this knowledge together to develop a couple of operations that helped both for other symptoms of Parkinson's and especially for tremor. So the targets, there was a small number of targets in the brain which were found to be effective for this. And the targets were treated with radiofrequency, which is thermal ablation of the target. These devices and imaging would be used to locate the target. A burr hole, a drill hole would be made, a probe would be put in, and a small lesion, a small hole burn there to interrupt the malfunctioning circuit. This ran into problems in the 1960s because similar techniques were used for psychosurgery, for lobotomies. There was a big kind of pushback against this whole area, and the helpful movement disorder surgeries were affected by this whole idea of doing surgery for functional problems, and kind of fell into disuse between that and the invention of the levodopa. Between the late 60s and the mid 80s, not much of this kind of surgery was done. The most common operation that remained during that era was something called a VIM thalamotomy, which was specifically for tremor. And we're going to come back to VIM because that is still the target we used. The idea that behind all of this, the reason for mentioning this is that the idea of making little holes in precise locations in the brain to interrupt malfunctioning circuits, it is not a new idea. It's an idea that has many decades of history. In fact, one of the techniques we used to use, and I'm senior enough to have started in that era before there was DBS. So this is how I started my practice of functional neurosurgery, and I well remember those days. We would stimulate the target before we burned the little lesion there. We would electrically stimulate the target and look for an improvement in the tremor. We'd look for the tremor to stop. And it was that observation that we could stop the tremor with electrical stimulation before burning the little hole that led directly to the development of DBS. The idea that, well, if we can do it with electricity, why not just permanently implant the electrical generator and take care of the tremor that way instead of making this destructive lesion in the brain? And so here we go with DBS, which many people are familiar with and have seen. This operation has been out there and FDA approved now for about 25 years. And there's a couple of targets that I had mentioned before. This top one, the VIM, is the main target that we use for tremor, both with essential tremor and with Parkinson's. We'll get back to that. But basically what DBS does, it's like stimulating before you burn the little hole. It's going after the same target, and it's doing the same thing. It's interrupting that malfunctioning feedback circuit, but it's doing it with white noise. Basically, it's jamming the signal rather than physically interrupting the circuit. Oh, let me go back there. The main justification for the use of DBS rather than making those lesions, first of all, it's well shown to be better than medical therapy for people who are medically refractory. And we'll get to that again, but medical treatment, especially for the Parkinson's patients, doesn't always work, has significant side effects, and the cost of medications can add up. There are newer strategies coming out for some of these things, Parkinson's in particular, not so much for essential tremor, but these are all experimental, investigational, and DBS works pretty well. It is for tremor patients, for people with essential tremor, it's basically a cure in a high number of these patients. I'm putting 90%, which is my own series. You'll see later in the talk, literature 75% or so, but they're good numbers. It's an effective treatment. It's also used for dystonia and other PD symptoms and works less well than it does for tremor, but it is effective and has fewer side effects than the medications do. Most of all, the big difference between DBS and the holes, the lesions that I was talking about, is that DBS is adjustable. You can change the settings. If you don't like what it does, you can take it out. Again, the VIM is the target. It works for many different kinds of tremor that involve this circuit. So there's postural tremor, resting tremor, intention, action. A neurologist will know all these things. You can also see unusual types of traumatic tremor, tremor from multiple sclerosis. And then the big one is, as I mentioned, essential tremor and Parkinson's. So the point here is that this target seems to be involved in the tremor mechanism for all of these. And so these are all people with these different types of tremor are all potentially treatable by targeting that VIM location. And here's an old trial from 2009 publication. This was a Veterans Administration hospital-based multi-center study showing that DBS versus best medical therapy for advanced Parkinson's disease, that DBS was superior. But the next slide is key. So, I just quoted you 90%, which is what I've had in my series. The tremor control numbers that you'll find in published literature is a little bit lower than that. But I've highlighted here, in particular for the Parkinson's patients, the efficacy of DBS for tremor specifically, and it's 75 to 80% over the long haul for these patients, meaning a 75 to 80% improvement in the tremor. So what are the advantages? I've mentioned a number of advantages of DBS. It's anatomically selective. You can call it minimally invasive. It's a little burr hole in a very small wire. It's non-destructive. It's adjustable and programmable. And I've listed here a number of the ongoing efforts to make DBS even better than it already is by new technology, mainly better imaging, new technology, rechargeable batteries, steerable electrodes, many other things that are in development. But it's basically refinements to a therapy that now has 25 years of good history of use. There are disadvantages, which is the reason we're having this talk today. DBS is not for everybody. Although we call it minimally invasive, it is still invasive. It involves shaving part of the hair. It involves making cuts in the skin. It involves drill holes. It involves putting wires in, permanent wires in a pacemaker. I had a patient come to me the other day who was interested in DBS and unaware of the fact that you had to have a pacemaker device to run it, that it just the wires alone are not enough. So there's hardware. You can run into hardware problems. There are rechargeable batteries. They're relatively new, but batteries, if they're not rechargeable, need to be changed every couple of years. These devices are flexible, but they do require programming. Programming means visits to the doctor. Not everybody wants to do that. It's not convenient for everybody to make those visits. There are limitations imposed by the presence of all this hardware in the body. There's restrictions on who can get an MRI. There are restrictions on doing other types of surgery in the presence of these things. And there are cosmetic issues. There are people who are so thin that there's nowhere to put the hardware, or where the hardware just wears through the skin. So there are still a number of problems that meant that DBS was not the be-all and end-all, the solution for everybody. So to quote from a famous movie, everything old is new again. And so the idea of not doing this with hardware and jamming the signal, but going back to that, making a little hole to physically interrupt the circuit, that idea never went away. We were looking for a better way to do it. And in about 2016, we got that. Now, what is a good reason to introduce a new therapy? Well, if there's no cure, if you have a therapy that has minimal side effects, something that's less invasive than what you already have, and a need that's seen by patients in the medical community, these are all good reasons to consider a new type of therapy. So focused ultrasound fit all these things. It got around many of those disadvantages that I listed on the last slide here that go along with DBS. It relies on a proven principle that goes back to all those lesions that we used to make with an electrode and radio frequency. But it has distinct advantages that I'm going to discuss in the rest of the talk today. So what exactly can this accomplish for patients? Well, with the permission of this patient, this is an example of one of our focused ultrasound patients at the time of surgery. So the patient comes in for her treatment. The upper left is what her spirals, straight line, and her signature looked like before we started. And on the right, that's what it looked like when we were done with the treatment that day. On the lower left, that's the MRI scan. The little white dot there is the focused ultrasound treatment. And on the right is a letter that she wrote me. And this is why functional neurosurgery is what I do. This is what you do it for. So this lady told me that she was able to write Christmas cards for her grandchildren for the first time in many years. It makes a difference in people's quality of life. And you can see here in an actual patient what it's able to accomplish. This lady, why did she go for this rather than DBS? This lady weighed 85 pounds. There was no possible way to put a DBS system in her, even had she wanted it. So she was a perfect candidate and did great. This is a good example of the kind of person who stands to benefit from focused ultrasound. So how does this all work? There is a need for better treatment of these problems in the United States. As I mentioned at the beginning, many people have tremor. The number who are correctly diagnosed is still substantial. Many of those people are refractory to control with the standard medications like propranolol and primidone, or they have unacceptable side effects. And this leaves about 75,000 people in the US who are potentially candidates for this, very few of whom actually get sent for the treatment. This is a common finding that these treatments are underutilized. This is a little of data both on essential tremor and on Parkinson's. 90%, but this is the key number. So that 97% of people who potentially benefit from focused ultrasound or similar therapies are never treated at all. The common reasons for this are apprehension. It's brain surgery. It sounds scary. People don't know much about it. Dr. Google is not always that helpful in giving accurate information. It's one of the reasons for giving the webinar today. So the biggest problem, if you want to call it, the biggest problem with focused ultrasound is that it doesn't get used enough. There are other therapies for tremors, as many of you are familiar with. We've mentioned a couple of times now, it's standard medical therapy. I would never consider somebody as a surgery patient if the problem could be controlled well with medication with acceptable side effect profile. In other words, someone comes to me and says, I don't want to take medicine, I want surgery so I don't have to take medicine. I really will basically not offer surgery to someone like that. I will tell them the goal of surgery is to get an uncontrollable problem and make it controllable. I will never promise a patient that I can get them 100% off medication. And I think that most of us in this field would consider criteria for surgery to be a problem that can't be controlled with medication, either because the medication doesn't work or because the side effect profile is unacceptable. There are things like wearable neurostimulators, weighted gloves, and assisted devices for tremor. These things are cumbersome and socially awkward. I mean, I see them. Not many people use them. The basic treatment for this is either medication or the kind of procedures that we're talking about today. And here's a little list: focused ultrasound. There's injectable. This is talking neurotoxins. We're talking about Botox there. That works for some types of tremor. DBS, radiofrequency thalamotomy, which we talked about. This is an interesting one, stereotactic radiosurgery, otherwise known as Gamma Knife. Gamma Knife, as you know, is a brand name. The general category here is SRS. I offer that as well. I've offered it a few times. We'll get to this in a moment, but one of the criteria for being able to use focused ultrasound is that the sound waves need to be able to get to their target. Occasionally, you will have someone who their skull is either not dense enough or too dense to carry the sound waves. And there is an older non-invasive way of doing this with basically a linear accelerator or with Gamma Knife. You can do that as well. You have less control over the size of the hole that you make because people have different sensitivities to radiation. It takes longer to have an effect. So a number of disadvantages, but just so everyone's aware that if someone, for whatever reason, is not a candidate for DBS, not a candidate for focused ultrasound, and is still interested in something like this, there are still other alternatives. But back to the main topic here, focused ultrasound, what's the approval status? The company that makes this, Insightec, has a history that goes back actually all the way to the same time that DBS got its approval. Here's a little timeline. It really became an FDA-approved procedure for essential tremor in 2016. So we're going on 8 years now. The 5-year outcome data is in there, which is a requirement of the FDA. So this is a well-established procedure now with a good history behind it now, going back at least 8 years. And this is a little flashy advertising picture from Insightec. It doesn't actually look like this when you're in the MRI scanner. It'd be pretty cool if it did, but no, we don't sell the curly swirls there. But the equipment, the hardware, does actually look like this. So there is the treatment actually uses sound waves to make a thermocoagulation lesion in the brain. So we are still burning a hole in there. The difference from the old days is a couple of things. Number one, we don't need to make a cut in the skin. We don't need to drill any holes. Number two, it's done inside the MRI scanner so that we can actually see the lesion. We can see the hole as we're making it. We can control the location and the size very precisely. You can even see the temperature you're heating the tissue up to as you do this. So that's what it means by the closed loop system with real-time imaging and thermometry. Basically, with the patient in the apparatus here, a patient is awake and interactive, as was the case back when we did lesions. Patient was awake in those days. There are now ways of doing DBS asleep, but a topic for another day. This does require people to be awake because we use both this anatomic imaging and real functional mapping, meaning that when we have our target, we can raise the temperature slightly and look at the effect on the tremor. Raise it a little bit more, see if the tremor is getting better. And we keep going, looking for improvement in the tremor and checking for side effects, dysmetria, interference with speech, anything undesirable. And we can make what's called a temporary lesion. Basically, we can raise the temperature of that little spot high enough that the neurons stop functioning temporarily, give us an idea of what burning a hole there would do before we actually make the permanent lesion. When we have mapped it out and the patient's happy and getting a good effect on their tremor, we raise the temperature higher. Again, we have precise control over both the anatomy and the temperature, and we make the permanent lesion there. To do this, to go in there, you can see the metallic thing here is a frame. Frame is on the patient's head, and this is an idea of what the images will actually look like when we're doing this. This is how we do the mapping with the anterior-posterior commissure. It gives you an idea of how it's a cartoon of how it works. Couple of things to understand about this. It's not ionizing radiation. It's an MRI, not a CT, so there's no X radiation involved. It is thermal energy. It does require that those sound waves get uninterrupted from the generator into that spot in the brain, and so there cannot be any air of any sort in the way. That means that people's heads need to be completely shaved like a bowling ball. Now, the nice thing about hair is it grows back, but I always have to tell people that it's a concern. There are some people who, that's a showstopper for people who don't want their head shaved. It does not work if there's hair there. Even a small air pocket will cause the sound waves to bounce off. So basically, we have our patients come in the morning, shave their heads, put this little frame on that's attached with pins. There's a bag of water that goes on the top of the head to conduct the sound waves, and that frame and bag of water goes inside the little helmet that you see here while we do the treatment. With each time we raise the temperature slightly, we then bring the patient out of the machine, do our testing, have them draw the little spirals, see how they're doing, how they feel, ask them if they're having any side effects, then go back in and do the next step. People will usually feel a little bit of discomfort when we're making these lesions. Some people describe it as that they feel like they're getting turned upside down. I've had people say that they hear things or they feel discomfort, a little pain. But each treatment, each time, each step with the raising the temperature lasts about 10 to 15 seconds. So most people will tolerate it very well. They also have a little button they can press to shut the whole thing off if they're really uncomfortable. So they do need to be awake. If we give people sedation, it will make their tremor go away. And again, this is something that we carefully explain to the patients in advance, kind of prep them, get them ready for this. Most people do quite well with this, and we've done this on some fairly elderly, frail people with spine curvatures that make it difficult for them to position on the table, and even those folks really do pretty well. As I said, you have to shave the head bald, and this nice lady smiling. This guy has a bathing cap on, and this guy probably didn't need to have his head shaved. I get those too, but it is important because, again, this is quality of life operation. And if someone feels very strongly that they don't want their head shaved, that's an important consideration. So what is necessary to be a candidate for this? Who's a suitable patient to send to have a consultation to discuss the possibility of focused ultrasound for tremor control? The diagnosis should be confirmed. I mean, we can do that if there's a question. We have an entire team of movement disorder specialists, including neurologists, neuropsychologists, nurse practitioners, surgeons. We have all of that at MGH. But most people, these are not generally difficult diagnoses to make. It's just that these are the indications for which it's approved. So they have to have the confirmed diagnosis. They have to be over a certain age. These are FDA requirements. And as I mentioned, they can't be sedated during the procedure. So people with profound claustrophobia or anxiety are not always great candidates for this. Usually, because we're in the room with them, a bit of anxiety, we can give a little sedation when we put the frame on, a little bit of anxiety, we can literally kind of be in there and hold their hands. But someone who's going to have a hard time, or who knows that they're too claustrophobic to have an MRI scan, would have a hard time with this. They have to fit. Some of our fluffier patients, it can be a problem. We can usually get around it, but that can happen. Modern MRI scans can accommodate people over 300 pounds, but they still have to fit in the MRI scanner. They also have to be with it and coordinated enough to be able to hit the red button to stop the thing if they are uncomfortable. So they need to understand how to use that. Anybody who's not qualified to get an MRI because of a non-MRI compatible pacemaker or other metallic things that preclude MRI scan would not be eligible for this. It is an MRI guided focused ultrasound. It cannot be done with CT. So MRI compatibility. And then I mentioned this thing about skull density, the bone density, the calcium has to be it has to be not too little or too much. The too little is more common in elderly patients. If they have osteoporosis that's too severe, the sound waves won't carry through. I have also had people with hyperostosis frontalis interna, where the bone is too thick. But That's pretty rare. The great majority of people fall into the range of acceptable bone thickness. And that's all about how many of these little beams of ultrasound can you pass through. And they have to have a sufficient number of ports, basically places that can be used to conduct the sound waves in order for this to work. And generally, different places do this differently. I will generally have someone come down and talk to me about whether they want surgery, whether they are better candidates for DBS or focused ultrasound before I order the skull X-ray. There doesn't seem to me to be a great reason to get a CAT scan on somebody for no reason. But what we try to do for people who are coming from longer distances, if at all possible, would be to get if they're interested in focused ultrasound, would be to get CT same day to try to make it as convenient as possible. Again, this is increasingly used. The most important number here is to notice is that this one, that as of 2021, focused ultrasound actually surpassed DBS in numbers of treatments for essential tremor. That's not true for Parkinson's at this point, although it's increasing. But there's more people doing focused ultrasound now than DBS for essential tremor. So the numbers have been going up every year. And well-reported clinical results in the top journals, everyone showing that this is a beneficial treatment. There's really no question about its efficacy. This is an interesting number. If you remember back to the slide that I showed about the efficacy of DBS for tremor, specifically in Parkinson's, just about the same number, not significantly different. So this works about equally well as DBS for tremor control. No serious adverse events have occurred. The overall improvement in disability, the number quoted here is 44%. This is a complicated number to figure out because it depends on what you call disability. Many people with tremor are disabled to the point that they can't button their buttons, can't bring a drink to their mouth, can't write, and so on. And other people, the disability is mainly a social issue, embarrassment. But overall, at 5 years, about half of these people still feel that they are significantly improved from baseline. But again, I'm trying to explain what the difference is between the 73% tremor control and the 44% functional disability control. It's that the tremor by itself is not the whole story in many of these folks. There can be side effects. This is, although it doesn't involve anesthesia or burr holes, it is still surgery. And I make that very clear to patients. You're still making a hole in the brain. It may be minimally invasive, but it is still surgery. It's because it uses thermal energy, you're actually burning a little hole there, as is the reaction to any other thermal injury. There can be swelling around that little lesion that we make. That area of the brain controls position and movement sense. And so it's fairly common in the days or first few weeks following the treatment for people to feel like they're a little bit uncoordinated or have a little bit of gait unsteadiness. We do send people home the same day. I like to, if at all possible, have them stay in the area overnight and come back the next day for us to check them out. Sometimes I'll even get a follow-up MRI scan the next day. I commonly will put people on a little bit of steroid medication to help with that swelling. That is generally gone over a period of a week or two as the swelling goes down. Numbness or tingling, I haven't seen it that often. They quote 33% here. That would be an indication that your lesion might be a little bit posterior. You know, again, when we used to map for DBS or for making lesions, we intentionally looked for the light touch area in the thalamus that was serving the thumb and first two fingers. Finding that area told us that just in front was the tremor spot, but it was fairly common for tingling in those fingers to be a side effect when you turn up the DBS. And when you make a focused ultrasound lesion, some people will notice a little bit of this tingling or numbness in those fingers. That's actually said to be the most long-lasting symptom that is least likely to completely go away in 1 out of 5 people. I have not had people come back to me and complain about that numbness. They'll notice it if you point it out to them, but it's not a functional issue for them. And again, it's fairly rare. It is often, if you get that tingling, as I mentioned, from the mapping data, it's a sign that you're really in the right place to get good tremor control. So those two things kind of go together. Again, a little bit more, Insight Tech provides these nice little videos, cartoons.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
So, kind of summarizing what I mentioned, the overall treatment time for this
during the treatment
usually takes the whole thing takes an hour and a half to do this. So including the time of shaving the head like this, planning, prepping, the overall treatment. I have people come in at 10 a.m. and they're done by mid-afternoon. That part, the time actually in the MRI machine is usually roughly an hour or so. So, again, we've talked about some of these benefits, that it gives immediate relief for the tremor, improvement in quality of life. You go home the same day. It has fewer side effects than the old days when we burned holes with an invasive probe. There's no implants, no ionizing radiation, no anesthesia. We talked about complications a little bit, relatively low risk compared to other procedures. And here they have, another little picture of before and after, but I think you kind of get the point here. Okay. So that's one side. Now, one thing to understand about this is we can only do one side at a time. This is another difference from DBS. With deep brain stimulation, typically it is two procedures. One procedure where we put the leads, the electrodes, the wires into the brain, and then a second one a week or so later where we put in the pacemaker part. With focused ultrasound, we are restricted in the same way we were for lesions when we burned holes with radio frequency in this target, the VIM. The muscles that control speech, the vocal cords, are also, when you think about it, muscles that are critically dependent on position sense. And so it was very common for people to have side effects of speech if you turned the stimulation up to high with DBS. In the days before DBS, we could never do that procedure on both sides. You were limited to one side for a VIM thalamotomy, because if you did both sides, people could not talk. With focused ultrasound, that's no longer the case. You can do both sides, but you cannot do them at the same time. And it is for that same reason. If you do both sides at the same time, you run into problems with people's becoming dysarthric. Like the radiosurgery that I mentioned before, though, it can be done staged. So the FDA requirement is to wait at least 9 months between the two sides. They, again, need to be over a certain age. And the rest are just the same requirements as for the first side. But it is important for people to know that if they're coming in, they're going to get one side treated. Many patients will decide after the first side is treated that they really don't need the other side treated. In many people, one side has much more prominent or worse tremor than the other does, and one side is enough. Other people will say, hey, this is great, I'm happy with it, you don't need to do the other side, and then they'll call you up 3 or 4 months later and say, I'm really happy with my right hand now, but when I try to hold a plate, my left hand is now making things worse. I'd really like the other side done too. It's so common for people to eventually want the other side done that when I shave their heads, I have one of those little baldy shaver things, and I give it to the patient. And I say, here, this is yours. When you come back in 9 months, bring it with you. It actually has a somewhat higher figure. This is from Insight Tech. They'll say, 80% improvement on the second side compared to the 73 for the first side. But this is a 6-month follow-up. It's a shorter follow-up. This hasn't had approval for as long, so these are more favorable numbers. But this is largely because these are not 5-year data. I think it works just about as well as it does on the first side. Basically, the same sort of profile of side effects. When you stage them like this, you really don't run into the speech issues. So finally, what about coverage for this? Briefly, there is most, but not all, insurers will cover this. There are a few that don't, so you always want to check in advance. Medicare does cover it. The Blues cover it, but there are a few ones, and why it's not universally covered, who knows? But it is important to check with the insurer to make sure that they actually do cover it. Here's a list of the ones that we know cover it, but we always check and we always pre-authorize. We would want to do that before having a patient come in from a long distance to talk about this. All right, so just in conclusion, kind of wrapping up here, so I can leave some time for questions. MR-guided focused ultrasound is a proven, non-invasive method of really bringing back this old tried and true approach of making a lesion to interrupt the malfunctioning circuit that causes tremor, mostly for people with essential tremor and Parkinson's, tremor-dominant Parkinson's. The overall outcomes are similar to those for DBS. As I mentioned, there are differences between the two in terms of adjustability, in terms of the issues that go along with hardware and so forth. No surgeries without risks or possible side effects. And particularly when it's surgery to improve quality of life, we really hold this to a very high standard of safety and have very thorough discussion about patient goals, and having realistic expectations is really a point of emphasis. And for many people who are interested in this, who are potential candidates, who don't want DBS, or for whom DBS is not a suitable approach, this is an alternative that works very, very well. And going back to that letter that I showed you earlier, people who get the tremor under control, it can make a huge difference in their quality of life. So with that, I'm going to show the final slide here. For more information about this, here's my email, contact information, and my assistant, Paula. And the QR code will also lead you to a page where you can fill out sort of interest. I would also welcome anybody to send any questions that don't come up today. I'm always happy to discuss this, discuss particular patients, or answer questions about this therapy and related therapies. All right, Mark, if you're there,
Yes.
We have.
Do you mind checking your chat real quick? I just sent you a message.
Yep, I'm looking. Okay. The first question was, are these done as an outpatient? Okay. Yes, these are outpatient procedures. As I mentioned earlier, there are things that we can't check when we're doing the procedure. We can check people's writing. We can have them wiggle their toes. There are a few things we can't. We can't have them get up and walk around the room. So we can't check whether they're steady on their feet. It can, as I mentioned, because of swelling around the thermal lesion, you can get a little bit of unsteadiness. It's fairly common to see that in the days after surgery. So it is outpatient. We keep people, after the treatment, keep them in the recovery area for an hour or two, have them get up, use the bathroom, do all those things before they go home. It's common for people to have their side effects kind of show up the next day. So as I mentioned, ideally, we like to have people come back to clinic the following day to check things out, see how they're doing. put them on a little bit of steroid medication, often to help with the swelling. On occasion, I'll actually get, especially if they've come from a long distance, I'll get an MRI the following day. We can get MRIs at the end of the procedure. It's done in an MRI scanner. But again, when you burn something, the swelling shows up the next day. So sometimes getting an MRI the day after the treatment gives us a better idea of exactly what our lesion looks like. But basically, long answer to the simple question, it is outpatient. The ultrasound device, well, the question is the ultrasound device non-magnetic and no wires? Well, the whole thing is done in an MRI scanner. So it has to be compatible with an MRI scanner. There are no wires that are in the patient, but it is an electronic device that has a control panel that's a permanent installation in the wall. It's not something portable that you can bring to any MRI scanner. It is a special MRI with special installation that goes partly in the wall, and then the helmet that you saw in the cartoon that goes on top of the patient. So in terms of wires, yes, there are wires. The ultrasound device uses sound, not magnets, but the entire procedure is done inside an MRI. So someone, for example, with non-MRI compatible implants, metal fragments from in the eye from an industrial accident, anything that is a restriction for other kinds of MRI scan would be a restriction here too. The next question here is the easiest way of placing a referral. The easiest way for referral is just, you have my contact information here and the phone number. Email me, call Paula. You can certainly go through MGH Neurosurgery. We try to coach them to get these directly to us, but I don't mind at all contacting me or my assistant directly, and then we can get it to the right place. If it does go to MGH Neurosurgery, again, generally they know that I'm the guy who does the focused ultrasound. And just writing essential tremor is usually enough. The patient will then tell me that they're interested in the focused ultrasound. But we try to make it as easy as possible. And let's see, I don't see anything else in the question and answer right now. Mark, do you have anything else?
No, that was it.
Okay. Well, for anyone who's still there, again, when you get somebody talking on the topic of their favorite thing to do, it's hard to get them to shut up. I'm very happy to talk more about this, go into greater detail about how any of these things work with anyone who's interested, details about who is a candidate, who's not a candidate, what the mechanism is, what the differences are between DBS and focused ultrasound. Anyone interested in any of those things, please get in touch. I'm happy to talk about it. And again, this is something, the biggest challenge is that people who are potential patients for this, people who stand to benefit from it, don't know about it, or are misinformed about it, or just don't ask questions. And I want to emphasize that nobody coming to see me for a consult is going to get hauled off to the operating room same day. We're not there to twist arms. I have many patients who come down and talk to me and decide not to have treatment. I have people come down and see me and have treatment 5 years later. We emphasize in our functional neurosurgery and our approach to this, we emphasize to everybody, I'll actually tell the patient, you can think of this as like a facelift for the brain. We're not curing aneurysms and tumors with this. We're improving quality of life. People need to want to have it done, understand what the risks and benefits are for this, and a well-selected patient with realistic expectations is going to be a happy outcome. Upper age limit is, there's another question here about upper age limit. No, not really. I have done people in their late 80s with this. Anticoagulation is the other question here. That's a good question. Okay. And the answer is a bit complicated. So we're using thermal energy. We're burning a hole in the brain. And And if you know about how we actually do surgery, we use thermal energy to stop bleeding. So the risk of hemorrhage from a lesion like this is very, very low, just as it was back when we did this with radiofrequency in a probe. However, if a patient is on anticoagulation, my buddies at Inside Tech won't show up because technically the FDA approval that they got says that the patient can't be on anticoagulation. Generally, you know, I know colleagues of mine who do focused ultrasound who will do it in people who are on at least antiplatelet agents. The way I suss this out, the way I approach this is most people who are on full anticoagulation, these days it's usually apixaban, Eliquis, it's usually for atrial fibrillation. The risk of being off for 2 or 3 days is very low. To make everybody happy, I will usually have those patients be off for that amount of period of time, for 24 hours before the procedure, 24 hours after, maybe a total of 3 days off of that. Antiplatelet agents, generally the same. I think as time goes by, that contraindication is going to go away. And you know, I personally, if I didn't still want my Inside Tech buddies to be there, they're good people to have around. They have a lot of experience with this. I would probably let people come in on antiplatelet agents. Even with everything I've told you, I would be concerned about doing this in someone who's on full anticoagulation. So I would stop that for a couple of days. I do that for other elective procedures like this. And it is, again, something that I would talk to the patient about. And we often will ask for clearance from the cardiologist and get a good notion of what the actual risk would be. Once again, getting back to what I said, this is it's a facelift for the brain. It's for quality of life. You don't want to take any significant risk of having somebody have a stroke in order to get this done. So we do that on a case-by-case basis, but the simple answer is they have to at least briefly be off anticoagulation when this is done. Okay. Well, again, thank you everybody for coming to the webinar today. And I encourage communication. Let me know if I can be helpful in any way. Happy to answer questions and to be in touch with everyone. Thank you very much.